Hey everybody, Dr. Anthony Kaveh here to share with you the top 3 things you need to ask your doctor before the sleeping medication kicks in. Because I have seen way too many patients cancel surgeries out of fear. Did you know that 1 in 5 patients may cancel elective surgery because of fear of the general anesthesia alone? So I had a patient once, and this might sound like a crazy story. It's actually not the craziest story by a mile, but one that demonstrates just how important it is to ask these patients, ask these questions of your doctor. I called a patient the night before their surgery, and they were very scared. You could tell it from their voice. They didn't ask me any questions. They showed up the next morning to surgery, and I kid you not, they were high on cocaine. So high to the point that all of the patients around them in the waiting area were freaking out. They're like, who is this person next to us? This patient was so terrified because of the fear of surgery compounded with being on cocaine in the moment that that patient was asking where to send his inheritance to, and this is like a 20-something-year-old boy. Like, he's not someone who is at risk of dying from a minor surgery. I'm not downplaying what he was experiencing, but when you're a patient, you hear the patient next to you asking about where all of their bank account should be diverted to if they don't make it, and et cetera, last meal, blah, blah, blah. It is not a source of confidence. So the point here is that when patients have expectations, they can be prepared. And when you are prepared, you can be empowered to take care of your body. And unfortunately, in the United States and across the world, in operating rooms like this, we calculate surgeries as being successful or not on a very binary basis, 0 or 1. 1 if you came out alive, and 0 if you didn't, especially from the anesthesia perspective. But what that doesn't capture is that patients who aren't prepared might come out alive at the end of surgery, but maybe with a higher risk of infections, maybe PTSD, maybe post-operative depression, maybe post-operative cognitive dysfunction. Maybe they'd be like that individual who was so terrified that they almost ruined their whole life and would have died on this operating room table had they not ultimately, pardon me for saying this, but fessed up to using the cocaine, because that could be lethal with anesthesia. It's not 0 or 1. You are a human being. You are not just a number on a piece of paper, no matter what the medical system will try to do to you. So the point of these 3 questions is that the last thing that goes through your mind, I don't want it to be, what if this happens? I should have asked my surgeon this. What's my anesthesiologist going to do to me? Because what you fall asleep with will influence how you wake up, and you deserve to fall asleep with the best possible mindset, having asked these questions to reduce your fear so that you can wake up with a lower chance of those complications, and we'll have our live Q&A at the end. Number 1 is to ask about this code RBA, risks, benefits, and alternatives. So I want to know in the comments here, who has heard of risks, benefits, and alternatives? And I'll give you a shout out because I have like twice had a patient ask me this. I think they were both lawyers, actually. So most people don't even think to ask this, much less know how appropriate and important this is. So I'm waiting for the first person here. Oh, well, I guess not surprising, Gabby has heard of RBA, maybe because we talked about it in other videos, but the risks, benefits, and alternatives is, oh, here we go. Lori has also heard of it. Good. Linda has not. Good to see you, Linda. And yeah, well, Gabby was in surgical tech school, so of course she's going to be more likely to have heard of it. But I'm happy Cindy's been told the risks, but here's the catch, Cindy. I don't know if you were told the other set of risks. Risks, benefits, and alternatives is not just the risks of surgery. Get it? This is the risks of not doing surgery as well. So this is really important because every decision that your doctor has to make, and I'm a doctor as well. I'm not anti-surgery. I made my living for the majority of my life doing anesthesia for surgery. So I don't think surgery is bad, but it's not right by patients if they don't know what the risks of not doing surgery are. For example, this FBSS, failed back surgery syndrome. Have you heard of FBSS? Let me know in the comments. I'll give you a shout out if you have, because far too many patients with debilitating back pain don't always consider what are the risks of not doing surgery. The risks of doing surgery, like someone just said there in the comments. But when somebody has worse pain after a surgical operation in their back, maybe from scar tissue that now brings tissues more tightly wound together, maybe from a complication, like a neurological compromise that might cause worse neuropathic pain in the lower extremities or in the back. Maybe it's a complication from anesthesia. Who knows? There's so far too many complications to list here. And my goal isn't to scare you, but to empower you so that you can make a confident decision to the degree possible. Of course, you're not going to have all of the cards. You're not going to have a crystal ball to know what can go wrong. But suffice to say that any surgery, big or small, absolutely has risks of making things worse. And as long as those risks are less than making things better, you should be okay. So I just see people here have heard of FBSS, absolutely. And I'm sorry that Linda has also suffered from this, but you're not alone. And Todd is bringing up the risk of bankruptcy. We're going to talk about that because doctors never think about that. I certainly do not think about that. At least I didn't until I started doing this more for you guys. So other conditions that patients don't think about are chronic post-surgical pain. When the acute pain of surgery, which should ordinarily last anywhere from 9 to 12 weeks, maybe a little bit longer depending on the surgery, becomes chronic long-term pain. Or post-operative depression, post-operative cognitive deficits, medical PTSD. I'm not here to scare you about surgery. Surgery is incredibly safe on a 0 to 1 basis. But if you're a human being and you deserve to have more than just 0 or 1 to define the rest of your life, you deserve to think about the reality of what's happening to your body with the surgery and the anesthesia. Which is why number 2 is to feel comfortable, and you should ask your anesthesiologist, especially if it's your first surgery, what will happen to my body? Your anesthesia expectations are huge. Why does this matter? Because things will happen to your body in the unnatural state of anesthesia, the general coma that we're putting you into. It's really a near-death experience, but not one that you will retain any memory from, but one that nonetheless can play a huge role in it for the rest of your life. For example, I had a patient who came to me before surgery, and his voice was kind of funny. And I said, oh, tell me about your voice. We need to know about your voice because if you have any vocal cord dysfunction before surgery, if we place a breathing tube to connect you to the ventilator, like the one behind me, that breathing tube might make a pre-existing vocal cord injury worse. Well, he said, oh, I don't know what's wrong with my vocal cords. And I said, oh, like, were you born that way? What happened? He said, well, I don't know, but I think after my last surgery it happened. So lo and behold, this individual, this poor gentleman had never even been told he was going to have a breathing tube placed for his surgery. And he sure enough had some degree of vocal cord dysfunction that led to hoarseness. Now, to be very clear, this is rare. In most cases of vocal cord injury recover without any incident after maybe, if it happens at all, a couple of weeks, maybe a month or 2. Sometimes it doesn't. It's a risk of any surgery. That's why we try to place those breathing tubes very carefully, very gently past the vocal cords. But hey, this is medicine. It's reality. Bad things can happen. This individual had never been told, so he was left wondering for so long why surgery and his gallbladder gave him a hoarse voice. All of his family members asked. He had no idea. He was totally dumbfounded until I had to break it to him. Well, you had a breathing tube for that surgery. So had he not known, I would have repeated the breathing tube placement the same way, and that could have worsened the injury. So if you don't know what happens to your body, you don't know how to prevent bad things from happening if they happen in the first place. And that is why your feedback influences what your anesthesiologist does. Whether it is you asking your anesthesiologist what medications will be given for nausea. So this stuff here, for example, do you guys know what this is? I won't show you the label. It's in this amber container. I'm curious. I'll give you a shout out. I'm gonna monitor here. But whether it's the nausea and vomiting that things like this can induce, hey, by the way, Heidi, thank you for that reminder to please hit that like button, much appreciated. Whether it is the sore throat that we talked about, whether it is any of the other number of, here we go, sevoflurane, sorry for the interruption, guys, but Linda nailed it. This is one of the anesthesia gases, sevoflurane, and I'm not going to open it because it will put me to sleep right now as it comes out really fast, and that would not be good for a live stream. So I'll give a quick shout out here to Joan. I'm wishing you the best for your total shoulder replacement. So whether it is the broken teeth that can happen, if you have loose teeth, you need to ask your anesthesiologist, what is going to happen to my mouth to prevent my teeth from getting worse? If someone loses a tooth from a breathing tube being placed, it can be fatal if that tooth goes into their lungs, potentially. Whether you are at risk of post-operative depression or having a hyperarousal or having a flashback from medical PTSD, if you don't know what to expect with your body, how can you prepare? If you don't know what the risk to your heart is going to be, how can you prepare? So we're going to talk all about this in a second, but just one little plug, if you could share what you learned with loved ones, please empower them, because our broken healthcare system won't do this. Certainly is not going to tell you guys to ask your anesthesiologist these questions. And even though people think, oh, anesthesia is just a nap, it's not. It can be so safe and can allow for such a comfortable surgery experience. But I know from you guys watching that that's not always the case. And far too many patients, out of ignorance of knowing what to expect, can't have the safest and most comfortable surgery experience or childbirth experience. I know that one for a fact from numerous close friends who have had nothing explained to them, at least nothing to give them appropriate expectations. But going back to number 3 here, then we're going to talk about specifically the PTSD. That's a big one because I just see it so often in medical settings. But number 3 is to ask about the recovery timeline. So not too long ago, I had a patient who, as the white medication was going into their veins, the surgeon was next to them and they're like, oh yeah, I wanted to ask you, when is it gonna, and he just fell asleep. And the instinct is to laugh, like, oh, well, I guess they won't get their question answered. But that's the last thing that the patient was thinking about before they fell asleep. For us, it's no big deal because we do this every day. We know the answers. But if you don't ask, you're not just going to magically be downloaded this information under anesthesia. I'll tell you that. Doctors forget to acknowledge things like money, like childcare or elder care. They forget to, not all doctors, but it's easy for us to forget that you're a real person with a real job. You're not just someone here in a gown about to be put to sleep and have some part of your body cut open or cut out. I'm not saying that surgery is bad, guys, but I'm saying that if you aren't advocating for yourself and asking those questions about how this will impact your life and how you can mitigate its effect on disrupting your life and your care for others, like, I don't know, your job, your finances, your follow-up appointments, when will the stitches come out? Will I be able to walk? These are all questions that patients I have seen ask in the last minute before falling asleep. And I'm grateful that they had the courage to do so, because you have enough stresses as it is in this room: cold, hungry, afraid of the pain that you might wake up in, etc. You don't want to add things that you can control to the list of things that you cannot control. And don't assume that the doctors are going to just tell you everything up front, because we're busy. We're not thinking about you in that global sense. I think we should, but most doctors, correct me if I'm wrong. Please leave a comment. Correct me if I'm wrong. If you've had an interaction that has not acknowledged you as a global person, I would be shocked if no one answers. Not because doctors or nurses or PAs or NPs are bad, but because this healthcare system does not have you at the forefront of it. Unfortunately, it's why I'm here. I think that you deserve better. So with that said, please share what you learned with others. We're going to jump into some Q&A here. If you could like and subscribe to keep up with all of my lives, it would help me do this for you more often. Magic Healer Clairvoyant, thank you for the kind comments. Oh, this is a very common question. Will someone that has a high opiate tolerance have any problems? Is it a worry? It's very important. You need to ask your doctor what will happen if they have a history of opioid use. Will they need more of the white stuff, more of the gas? Will they wake up in more pain? Very important to consider. Is epidural better for your recovery because it can process it better? Well, it depends on the surgery. In many cases, an epidural can help minimize many risks associated with anesthesia. Absolutely. Danny, thank you for that super thanks. What are the risks of maximizing propofol and minimizing sevoflurane? We don't know if propofol has a less long-term impact on your central nervous system than sevoflurane. We really don't know. We would like to think that this is more gentle, but by and large, there's probably not a big difference that we can detect. That being said, if you're having a minor surgery, you can get IV anesthesia for a minor surgery, but you can't get gas anesthesia without having some sort of breathing tube to deliver that from the ventilator behind me down your throat into your lungs. So if you're having a minor surgery with propofol, that's likely going to have less impact globally on your body, probably because maybe the surgery is just less intense in general. Tina is good to see you, Tina. EDS, more anesthesia, certainly in some cases, but not in all. We really don't know exactly why some EDS patients need more and some don't. Can you ask a list of questions, or is that too much? Linda, I don't think it's too much at all. I think it's wrong to not ask a list of questions, go to sleep with worries that could be addressed before, and then end up with complications after, or end up not having the best outcome you deserve and causing more problems for yourself. You deserve better. Tracy, good to see you. What are the chances an acute respiratory failure 1 to 2 days after knee replacement surgery? Well, it depends on what caused it. Was it because of aspiration? Was it because of chronic COPD? Was it because of maybe a viral infection before the knee surgery? I can't comment, certainly without knowing what caused it and what the risk of that recurring is. 25 questions is not a small list, Linda, but it's certainly better to ask as many important questions before it's too late. Because once you inhale all this gas, it takes time for it to come out. You can't just magically extract the gas in your brain. It takes time. I'd rather you fall asleep much more comfortably with questions answered. Can anesthesia affect an MD? Of course. Danny, docs don't like DNR. Why? Docs, it's not about what docs like or don't like. It's about what patients want. In the operating room, I don't like DNR because it's not really a question of DNR in the operating room as much as that DNR applies to places outside the operating room. Because if we do something to your body that puts it into a temporary near-death state, like maybe an overdose of a medication, maybe bleeding, maybe something with the ventilator is not going wrong, is not going as expected, and if we can reverse that in a number of seconds, and you would have no lasting deficits, well, we would suck to know that we could fix a problem and just watch someone die because of it. That's why anesthesiologists don't like DNR. Twilight sleep is not an official term. It typically refers to sedation and receiving a benzodiazepine like midazolam and maybe an opioid like fentanyl. Will your other kidney be okay after having a kidney removed? Jennifer, I certainly hope so, but that's something you need to ask your surgeon. It's a very, very important question. Those meds are fat soluble. Yes, Gabby, nearly all anesthetics have to be fat soluble because your brain is made out of fat. So those medications have to be able to dissolve in the brain. Why do you take no transfusions? Oh, what's my take on no transfusions? Well, depends on the context. If it's a minor surgery, it probably doesn't matter. If it's a major surgery, it probably matters very much. That's why it's a one-on-one discussion you should have with your doctor and your anesthesiologist. I agree, Jennifer. Good luck. How does stitches affect intestines? Well, that's a little bit of an in-depth question. Usually we were not, well, we'll leave that one for a different discussion. Depends on the type of suture, whether a staple is being used, what the surgery is, etc. But any type of manipulation to intestines, sutures, staples, even just touching them, can cause what's called an ileus, or cause them to become paralyzed and lead to nausea and vomiting after surgery. Darian, good to see you. What is the time to have surgery for chronic pain? It might help, might do nothing, small chance it makes it worse. Yes. So that because you are looking at exactly the analysis your doctor needs to be doing with you, you can tell there is no right or wrong answer for that. It depends on the individual. And if you don't have that discussion in a one-to-one fashion, I would be concerned that potentially there's something that's not being explained adequately to the patient. Buprenorphine and other meds in the OR. We usually don't give buprenorphine in the OR because it does not provide enough analgesia compared to other opioids, and it blocks the effects of other opioids. Hey, Margaret Lewis, I am grateful that you're able to ask your anesthesiologist about it. I'm sorry you had the sore throat. I hope that and the fat lip quickly resolved after surgery. Jean, you are so welcome. And You're right that most patients don't know about the effect of EDS globally on the system, and yeah, likely metabolically as well. I hope that you can advocate for yourself and others. I want to end with one last question. Sunshine, no sprinkles. Is it necessary to tell the anesthesiologist you're taking Benadryl? Absolutely. Please do. It makes, now that would likely a less less impactful than someone who's, for example, taking opioids every day, but still we want to know what you are taking. It influences the anesthesia, or it can. Last question, love for life. I like your username. I have dish having neck surgery. How do they intubate? It depends on exactly what your anatomy looks like. If there is compromise, regardless of the actual condition, of your ability to extend your head or your neck, sometimes, and I'm not saying this is going to be you, I need to know more about exactly what your x-rays, maybe what an MRI looks like, but we will either do anything from an awake elective intubation with minimal sedation, and then we're down to a normal asleep intubation, maybe with a video laryngoscope. But I would highly encourage you to speak with your anesthesiologist to understand what's going to happen so that you know what to expect when you wake up. So you're not surprised. You're not going to sleep wondering what's going to happen, because that level of fear, uncertainty, and or doubt can impact how you wake up, and you certainly deserve more. I hope nothing's on purpose, Heidi. I don't know what Karima was asking, but please remember that you all have more power over your health than you've ever been told.